Yes, sir, we are good to.
Okay. Esteemed faculty and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on behalf of the entire team at Emcure Pharmaceuticals. We at Emcure are proud to present Lipid Webinar Series, our highly anticipated scientific program dedicated to exploring the multifaceted landscape of managing dyslipidemia. We all know that on 29th September, we'll be celebrating the World Heart Day. Although substantial progress has been made in the diagnosis and treatment of acute coronary syndromes, cardiovascular disease remains the leading cause of death worldwide, with nearly half of these deaths due to ischemic heart disease. Globally, 12% of the disability adjusted life years lost annually are attributable to IHD. Dyslipidemia is one of the major risk factors for ACS. Today's program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of patients affected with dyslipidemia. Our distinguished speaker, esteemed moderator, and expert panelists are poised to share their knowledge, insights, and practical wisdom to empower us in the fight against the health challenge. We are thankful to our speaker, Dr. Abhishek Kasa sir, moderator Dr. C.B. Keshavamurthy sir, and panelist Dr. R. Ravindran sir, who have generously decided to share their time and wisdom. Emcure is privileged to have a role in facilitating this bond. Let me have the privilege of introducing our esteemed faculty for today's program. We have respected moderator today, Dr. C.B. Keshavamurthy sir. Sir is Chief Consultant Interventional Cardiologist and Head of the Department at Manipal Hospital, Mysore. Sir is past President of CSI Mysore Chapter. Sir did pioneering work in primary angioplasty at Mysore. Sir established interventional cardiology centers at Salem and Erode in Tamil Nadu and performed several first ever procedures in that region between 2000 to 2004. Sir has several national and few international publications and presentations to his credit. Sir has teaching experience as DNB teacher at Vikram Hospital, Mysore. Sir is principal investigator of landmark trials like Rocket AF, Reduce It, Credence, Horizon Trial, and 33 other national clinical trials. Sir also participated in registries as primary and co-investigator. Warm welcome to you, sir. Let me have honor to introduce panelists for today, Dr. R. Ravindran sir. Sir is consultant interventional cardiologist at Ray's Clinic, Chennai. Sir has extensive experience in performing right and left cardiac catheterization, coronary angiogram, percutaneous coronary interventions, intra-aortic balloon pump placements, STEMI lysis, permanent pacemaker implantation. Sir has expertise in antenatal cardiac care and peripartum cardiomyopathy with 13 years of academic and 6 years of clinical experience in cardiac care. Sir won Best Doctor Award in 2010. Sir has memberships in Cardiology Society of India, Indian Society of Cardiology. Sir has published papers at reputed journals and presentations at various conferences. Sir is currently investigator in many ICMR research studies. Thank you, sir, for accepting our invitation as panelist. Let me have honor to introduce our expert speaker for today, Dr. Abhishek Kasa sir. Sir is interventional cardiologist at Apollo Main Hospital, Grims Road, Chennai. Sir is visiting consultant cardiologist at Apollo Clinic, Tambaram, Chennai, and AK Heart Clinic, Salurpeta, AP. Sir is trained in advanced echocardiography, interventional cardiac procedures, and cardiac critical care. Sir is assisted and performed more than 2,000 plus cath procedures, including simple to complex coronary interventions. Sir is member of American College of Cardiology and associate member of ESC, SCAI, and HFSA. Sir has participated at various national conferences. Thank you, sir, for joining today and agreeing to be speaker for today. And finally, I would like to extend my special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me brief you all on the meeting agenda for today. We'll kickstart the program with the opening remarks and context setting from our respected moderator, Dr. C.B. Keshavamurthy sir. The meeting will proceed further with the session on management of dyslipidemia in ACS by Dr. Abhishek sir. Following this, we'll have quick comments on the session by the esteemed moderator, and then there will be panel discussion where esteemed faculty will participate. I request audience to post their questions in comment box so that we can questions at the end. Without further ado, let's to enhance our understanding of dyslipidemia. I request our moderator, Dr. C.B. Keshavamurthy sir, to share his opening remarks on today's topic. Over to you, sir.
Thank you so much, Dr. Rishikesh, and thanks to Emcure for organizing this very important webinar and very interesting and a kind of a evergreen topic for cardiologists and physicians across the world. I thank the audience for taking that time off and joining this webinar, and I'm sure it will be a great learning experience. On behalf of my co-panelists and the speaker, I thank you all for joining, and we'll all have a great learning experience. In the Indian scenario, like Dr. Rishikesh was just telling us, the coronary artery disease epidemic has exploded. We are now seeing more and more cases. We have the world's youngest patients with myocardial infarctions and acute coronary syndromes. We are also sitting on the hotbed of being the highest incidence of coronary artery disease and vascular disease. We contribute about 60% of the world's vascular disease burden. And especially in our geographical location, especially, we know that South Indians have the highest incidence of vascular disease compared to any other population across the world. It's also a hotbed because we have the difficult situation of economics of our country, the large volume of our patients, the poor acceptance of therapies when we give them, especially in primary prevention. It's so difficult to convince a patient to take a statin despite very high levels of lipid profile. I'm sure you would all have come across such situations. And today's topic is so much relevant in that there's a lot of new information pouring into treatment of dyslipidemias in situations like acute coronary syndromes, acute TIAs, and strokes. Every day something new is coming up. Some of the developments are very exciting, and in a few years, we may be on the verge of producing an anti-atherosclerotic vaccine by advances in technology. With that introduction, with our expertise and our kind of knowledge and real-world practice of seeing a large number of patients with dyslipidemia, Indian physicians and cardiologists perform very well in terms of controlling lipid levels to targets. The Lipid Association of India has specified several targets which are peculiar to India, addressing these concerns of high-risk patients, patients with recurrent events, patients with ACS with multiple risk factors. What do you do with these patients in primary and secondary prevention? So putting it all together in this first talk of the series, Dr. Abhishek will now tell us how to deal with dyslipidemia in acute coronary syndrome. Dr. Abhishek.
Thank you, sir. So let's move on to the topic of the day.
We can see full screen.
Okay, I'm turning off the video so that my slides will play without any lag.
Sure, you can do that. When we come back to the discussion, we can put it.
Yeah, that's what, sir. Otherwise, there will be a lag in throughout the talk. So, am I clear now?
Yeah, your slides are visible. Voice is also quite clear.
Okay, sir. Let's move on. The management of dyslipidemia is a topic for the day. So, outline we'll know what is dyslipidemia, some Indian data, and dyslipidemia in ACS, and management and summary. Dyslipidemia refers to either lipoprotein overproduction or deficiency, which is the consequence of abnormal lipoprotein metabolism, leading to increased total cholesterol or LDL-C, triglycerides, or decreased HDL. India has the dubious distinction of having the highest number of CAD patients in the world. Case control and prospective studies in India have reported that lipid abnormalities, especially raised total LDL and non-HDL, triglyceride, and ApoB, are the risk factors. Lipid management based on LDL-C and non-HDL target is crucial to reduce the incidence of coronary artery disease in both primary and secondary prevention setting. A number of challenges exist which include the premature outcomes of major CAD risk factors, large burden of premature CAD now in India with high prevalence of raised total LDL and non-HDL cholesterol, familial hypercholesterolemias, hypertriglyceridemia, and elevated lipoprotein, small a. low status, that is low socioeconomic status of population level and individual level awareness and treatment of dyslipidemia, and extremely low status of guideline recommended control in community and in clinic is the barrier for optimal lipid management. There is also a lack of large randomized control studies of various pharmacological and clinical interventions in India to develop context specific evidence-based guidelines. This is one of the beautiful study which is published in latest Indian lipid guideline 2024, which was used in there is a significant epidemiological and genetic and causal association of raised total cholesterol,
Sir, your voice is not audible.
now.
Little
Hello.
bit improved, but not like previous at the start.
Hello now.
Yes, now it is fine.
Significant epidemiological, genetic, and causal association of raised total cholesterol, non-HDL cholesterol, LDL cholesterol, and triglycerides with atherosclerotic CV disease events and mortality. This is an ICMR India B study. In this graph of India map, where we see the hypercholesterolemia with a diffuse distribution, with red being a marked elevation of hypercholesterolemia in northern states and southernmost states like Kerala and Pondicherry, with a moderate rise in few of the southern states and middle northern states, and so on, with overall weighted prevalence of dyslipidemia of 82.2% in India. According to 2021 projections, 213 million people had a hypercholesterolemia and 185 had high LDL cholesterol, and low LDL cholesterol accounted for the majority of the dyslipidemia burden in the country, with overall prevalence of 66.9%. With hypertriglyceridemia, look at this pattern. There is a V in this, with southern states and part of the northeastern states with very high hypertriglyceridemia burden compared to few northwestern states. And coming to LDL, it's again a blanket-like picture where we can see the LDL, very high LDL levels are seen in the population of both southern as well as northern state, with few states like Telangana, Rajasthan, and Gujarat with a bit about of moderate control of low HDL cholesterol. And this is again important slide about the genetic population, the dyslipidemia in ischemic heart disease. Again, the greater prevalence of familial hypercholesterolemia in patients with ischemic heart disease, particularly premature ischemic heart disease, and in population with severe hypercholesterolemia, with almost 23-fold higher when patients have severe hypercholesterolemia. There is always an association of dyslipidemia with coronary artery disease or acute coronary syndrome, because it is a major risk factor for CAD, with increased levels of cholesterol is directly related to acute coronary events. So acute coronary syndrome is a major cause of mortality in India. Lipids play a crucial role in pathogenesis of ACS. Reduction of lipid parameters plays a pivotal role in secondary prevention. High total cholesterol or high LDL-C cholesterol are the major lipid abnormalities globally as well as in Indian population. So coming to ACS, it includes both STEMI and non-STEMI, which includes unstable angina as well. So cardiovascular diseases accounts of roughly 1/3 of all deaths worldwide, and they are the leading cause of death in majority of the world, particularly in developing countries like India, with most severe manifestation of CAD, which is responsible for half of all the CV deaths. With despite of invasive revascularization therapy, 5-year mortality rate for ACS patients is currently around 20%. There's a paradigm shift of lipid-lowering therapies in ACS and CV risk reduction, with intense lipid-lowering therapy with rapid achievement of LDL-C target goal in ACS patients seems reasonable. Lower the better, and you strike early, you strike strong. This is what we strongly do and implement to the patients. We always start with high intensity statin therapy as early as possible. If needed, we always add ezetimibe as well as PCSK9 inhibitor or bempedoic acid, and now inclisiran being available in India, we do add the drug to make the unstable plaque stable and cause CV risk reduction. Commonly available statins in India and doses for the overview to the general public. Atorvastatin at a dose of 40/80, we call it as high intensity. Rosuvastatin at 20/40. Coming to moderate intensity, that is 10 to 20 milligrams of atorvastatin, 5 to 10 milligrams of rosuvastatin, and pitavastatin of 2 to 4 milligrams. Low intensity is 5 milligram of atorvastatin and 1 milligram of pitavastatin. These are the three commonly available statins in India. So observational studies have suggested that South Asians and Indians are hyper responders to statin and may require lower doses to achieve the same effect. This group may also be more susceptible to statin-induced adverse effects, which we need to rethink once we are starting on high-intensity statin therapies. Statins are particularly useful in lowering the total and LDL cholesterol and triglycerides in high dose. Statins are dose-dependent and lipid-lowering efficacy varies for different statins. Rosuvastatin is water-soluble and atorvastatin is fat-soluble and are considered the most potent statins, and lower dose of these agents are considered as moderate intensity statins. Let's have a broader view on other drugs which we recommend in the guideline, that is ezetimibe in combination with statin to achieve the LDL target for early after acute coronary events. It is also used in combination for heterogeneous familial hypercholesteremia as initial therapy. Ezetimibe alone can cause 15% reduction in LDL cholesterol, and in combination with bempedoic acid can cause 40% reduction in LDL cholesterol in statin intolerant patients. Coming to bempedoic acid, which is maximally tolerated statin therapy, is approved, and it is approved for hypercholesteremia, mixed dyslipidemias, heterogeneous familial hypercholesteremia, and for ASCVD, and patients who are statin intolerant or on patients with statin, high intensity statin and ezetimibe. And it is indicated either alone or in combination with ezetimibe or in combination with statin ezetimibe, or for patients who are not statin tolerant. Bempedoic acid reduces LDL cholesterol by 25%. The risk of myopathy is low with this drug. No increase in new onset or worsening diabetes, which is seen with high intensity statin therapy. And there is a mild clinical relevance that it increases serum uric acid levels when it is continued on long run, and it has to be monitored. Coming to PCSK9 inhibitors, which are a bit expensive, available in India. Evolocumab is available in India, and these drugs reduce LDL cholesterol by 50 to 60%. Evolocumab is available as a subcutaneous injection administered at 140 milligrams every 2 weeks or 420 milligrams once a month. PCSK9 inhibitors are generally well tolerated with very minimal side effects. They are indicated for patients with CV disease or high risk of CV events or in familial hypercholesteremia. They can reduce the LDL cholesterol below 70 milligram per deciliter in high-risk patients or on maximally tolerated dose of statin or ezetimibe who fail to achieve the targets. They are also prone to reduce the risk of major CV events in patients with cardiovascular disease or post-acute coronary syndrome or stroke. PCSK9 inhibitors are very efficacious, but the cost has to be looked into the consideration before this drug is being started, or patient counseling plays a key role. And inclisiran, again, it's made available in India from this year. We are lucky enough to have it. Again, the cost is the main burning issue for this drug. It's a long-acting, small interfering RNA that inhibits the transcription of PCSK9, decrease in PCSK9 generation in hepatocytes, and increase in LDL cholesterol expression in liver cell membrane, leading to about 50% reduction in serum LDL cholesterol levels. Inclisiran is administered as a 3-month dose and later on twice a year, and for potential better compliance, which with PCSK9 we need to administer it every month or bi-weekly. That has overcome by this molecule. Inclisiran therapy is associated with 24% lower rate of MACE with no increase in unwanted side effects. It has also improves the compliance of the patient and causes the less LDL-C variability. Coming to fibrates, again in ACS, we don't talk about this.
Sir, your voice is weak.
Coming to fibrates, in ACS, we don't talk about this drug much, but most definitive indication for fibrate as a lipidologist or a cardiologist is for fasting serum hypertriglyceridemia more than 500, primarily to reduce the risk of pancreatitis. Fibrate monotherapy offers only a modest reduction in cardiovascular events without no reduction in stroke or CV mortality or total mortality. Combination of fenofibrate and statin in patients with diabetes may yield better outcomes in management of mixed dyslipidemias, but its use in ACS is not so high. Coming to fish oils, again, I think our Keshav Murthy sir has again one of the principal investigator and the trials on this. And in that, EPA in large doses may have a cardioprotective effects, and a randomized control trial of highly purified IPE showed significant reduction of major cardiovascular events. Bile acid sequestrants, its use is very, very less, and it is the only lipid lowering agent safe in women planning for pregnancy or during lactation. And other drugs like Bipomarazone or Lomotepide, I think let's move on to the next slides in lack of time. So landmark trials on statin in secondary prevention after ACS trial with atorvastatin 80 milligrams with placebo 10 towards reduction in composite endpoint with hazard ratio of 0.8. Florida, where fluvastatin was studied, and PACT, where pitavastatin did not significantly reduce any major ACS. And next, the PRO-IT TIMI trial with atorvastatin 80 milligrams versus pitavastatin showed the association of lowering.
Sir, your voice is weak.
And IMPROVE-IT. Hello, am I audible?
Yeah, now better.
Yeah, IMPROVE-IT with Simvast. I don't know because I'm close to my mic still because of internet issues. So coming to IMPROVE-IT, it is simvastatin with ezetimibe versus simvastatin alone. Again, simvastatin plus ezetimibe reduced the significant composite endpoint when compared. And antibody targeting PCSK9 can lower the plasma LDL-C levels by approximately 65%. In dedicated CV outcome trials, PCSK9 inhibitors significantly reduce the risk of major adverse CV events. Benefit was consistent in patients with baseline LDL-C of less than 70 who achieved an LDL-C of and PCSK9 inhibitors has emerged as a promising new therapy strategy to reduce LDL-C. Coming to inclisiran, again, the novel molecule, it offers long-term significant reduction in LDL-C with only 2 to 3 injections per year. And the main clinical studies on PCSK9 inhibitors in post-ACS setting are and Fourier trial, which had showed significant benefits on LDL lowering therapy and as well as MACE by all means. And so a few more studies to add on PCSK9 inhibitors, COPAX, EPISCEMI, and RT. And overall available evidence on the use of anti-PCSK9 monoclonal antibodies in ACS setting consistently shows a powerful and early effect of drugs in terms of LDL-C reduction and better prognosis without relevant safety issues. These findings support the use of anti-PCSK9 monoclonal antibodies in early phase of ACS. Coming to inclisiran, this Victorian initiate trial showed that in patients with ASCVD on maximum tolerated statin therapy with inadequate lipid lowering control, inclisiran was superior, achieving a clinically significant reduction. Coming to management of dyslipidemias, we need to know and stratify the patients based on the risk assessment, whether they come under the low risk group or a moderate risk, high risk, or very high. Based on that, we need to target non targets for these patients, and we need to achieve these targets by tailoring around the lipid lowering agents. Coming to the low risk group, if the LDLC target is less than 100 and 130, we can just continue with lifestyle modifications. And to the moderate risk group, any single risk factor like diabetes or hypertension, tobacco, or familial hypercholesterolemia of young with ASCVD, then we need to target the LDLC less than 100 with non-HDLC less than 130. And for high-risk individuals, this includes the diabetic or CKD with EGFR of 30 to 59 comes under stage 3, and heterogeneous familial hypercholesterolemia and hypertension plus one or more of the risk factors, or hypertension with target organ damage. We need to target the LDLCs to less than 70 and non-HDL to less than 100. Coming to very high risk group, these group include CAD, PAD, or cerebrovascular events or aortic events with imaging done showing more than 50% lesion in any of the two major vessels, or diabetes with more than 20 years, or with multiple risk factors with target organ damage, or heterogeneous familial hypercholesterolemia with ASCVD or risk factors with CKD with EGFR less than 30. We need to be a bit strict with LDLC reduction less than 55 and non-HDL less than 85. Extremely high risk are the group where they have recurrent episodes of CV events within a year in the same territory or different territory, including a peripheral vascular event or cerebrovascular event. These polyvascular individuals are patients with ASCVD, heterogeneous familial hypercholesterolemia with elevated lipoprotein A need to be more aggressive with LDL-C targets less than 40 and non-HDL less than 70. This slide is very important in your management part. Coming to dyslipidemia in ACS, the dictum is strike early, strike strong, and the currently available data on early administration of potent lipid lowering drugs such as PCSK9 inhibitors in patients during a vulnerable post-ACS phase have clearly demonstrated clinical efficacy of that strike early, strike strong approach, not only for rapid reduction of low density lipoprotein cholesterol to unprecedentedly low levels, but also for associated favorable composition of coronary plaque. Multiple evidence has shown that use of high dose statin has significant benefits in ACS. And the target LDL, as we saw in the previous slide, was less than 55 milligrams per deciliter with at least 50% reduction from baseline, regardless of age or gender. And non-fasting LDL should be measured as soon as after the ACS, as it varies minimally with food intake. The first line of therapy after ACS is to advise lifestyle modification, combination therapy including high-intensity statin along with ezetimibe or with bempedoic acid, and evaluation after 4 to 6 weeks of index event. Patients who present with ACS are at increased risk of experiencing recurrent CV events. Lipid management should be undertaken in context of comprehensive global risk reduction strategy. Like again, we must strictly emphasize on their diet, lifestyle, risk factor management, and implementation of cardioprotective drug strategies, which we will look in on the subsequent slides. And cardiac rehabilitation programs has to be emphasized on all the patients with ACS coming for the proper care. Despite the acknowledged clinical benefits of lowering LDL-C in patients with ACS, attainment of LDL-C target values remain suboptimal in this very high-risk setting. So in ACS patients, as soon as they get hospitalized, the non-fasting lipid profile is to be sent for laboratory, and we must target it to less than 55. High dose of statins alone may not be able to attain the LDL goal in significant number of patients. So addition of ezetimibe at initial stages of treatment is always recommended. And it is also recommended to add a non-statin drug of if LDL target is not achieved, which is not achieved less than 55 in 4 weeks, The choice might be bempedoic acid, PCSK9, or inclisiran. If patient is affordable, the early initiation of PCSK9 or inclisiran is always advised. Coming to management in setting of ACS, as per 2024 Lipid Association released by CSI, again, the non-fasting lipid has to be sent within first 24 hours. Start with high-intensity statin, like 40 milligrams of rosuvastatin or 80 milligrams of atorvastatin with azithromycin. If patient is elderly more than 75 years or patient with CKD stage 3 to 5, reduce the atorvastatin dose to 40 milligrams and rosuvastatin dose to 20 milligrams. And watch for the target LDLC. If target LDLC is achieved in the follow-up, continue the same. If not achieved, you need to add a bempedoic acid or PCSK9 inhibitor or inclisiran to the therapy to get the set target of LDLs. If patient is having recurrent ASCVD events within 2 years in the main vessel or the same artery, then you must target the LDL to less than 40. That is extremely high risk group, which we have seen in the previous slides. Same which is published in 2024 Clinical Journal of Cardiology, where again they divide the ASS patients to naive patients, patients on statin and ezetimibe. For naive with LDL, statin.
So your voice is weak.
Looking to the
So you
aim
are
at
not
reduction.
audible. Now it's fine.
You must aim at reducing the goals to less than 30% or by adding bempedoic acid or PCSK9 inhibitors. Suppose patients are on statin therapy with LDLC reduction reaching the goal only less than 25%, add ezetimibe immediately. Of LDLC goal reduction is more than 25%, need to add a PCSK9 inhibitor. If LDL goal is achieved with statin, continue the same therapy. If LDL goal is not achieved, or inclisiran is always an add-on handy in your toolkit. In acute coronary syndrome patients, non-fasting lipid profile is acceptable as a goal to achieve LDL target below 55 milligrams per deciliter as early as possible. I think the same points will be repeated. So I think this slide has been discussed again. All these are discussed. Coming to hypertriglyceridemia management. So patients with hypertriglyceridemia try to achieve a non-HDLC goal. Implement lifestyle modification, treat the secondary causes, mainly control your diabetes, control your thyroid levels. If still the triglycerides tend to be high, then measure the target levels. If it is 142, 152, 499, that is less than 500, atherosclerosis prevention is a main motto. Then you must first start on intensive lifestyle modification, lower non-HDL-C cholesterol by statin and by non-statin drugs like IPE, icosapent ethyl, which is available in the market now. But the price is still higher side, and again the dosing is very, very bothersome because patient has to take it at 4 grams dosing. And no ASCVD or diabetes, again lifestyle has to be emphasized first. Later on, lower it by statin or non-statin drugs. If triglycerides are more than 5 and above, with familial chylomicronemia syndrome, for pancreatic prevention, you can start them on 5 minutes plus minus or if required, you must refer the patient or a lipidologist for further evaluation and consider injection.
Again, sir, your voice is not
Voice is
audible, sir.
weak.
For stable atherosclerotic cardiovascular disease, am I clear? Stable atherosclerotic cardiovascular disease, lipid profile, fasting or non-fasting, start with rosuvastatin 20 milligrams, atorvastatin 40 milligrams, lipids at 4 weeks, and LDL-C more than 55 or non-HDL more than 85, add ezetimibe and bring it down to the set targets. Again, risk stratify them. If they're extremely high risk or moderate risk, intermediate risk or low risk, based on the set guidelines, we need to adjust the medications. All new lipid lowering agents like ezetimibe, bempedoic acid, PCSK9 inhibitors, inclisiran can be combined with statins to have a better outcome. Statins are safe and well tolerated, but are associated with muscle and liver toxicity, should be promptly detected and treated. Reduction of the dose or temporary withdrawal with careful reintroduction or changing to a lower potency statin may help. Statins are contraindicated during pregnancy and breastfeeding and are not recommended in premenstrual patients, menopausal patients with or without diabetes who are considering pregnancy or not using adequate contraception. An increased incidence of new onset diabetes has been noted with statins, and this is dose dependent and is particularly seen in patients with pre-existing metabolic syndrome and prediabetes. However, the benefit far outweigh the risk. Increase of hepatic transaminases occur in 0.5 to 2% of statin users within 3 months of drug initiation and is not significantly different from placebo in all RCTs. Routine use of muscle and liver enzyme monitoring either at baseline or subsequently not recommended by guidelines, and severe liver or muscle injury are uncommon and are usually reversible once the offending statin is withdrawn. Suppose if patients presents to you with SAMS, statin associated muscle symptoms, what to do? If symptoms present and if CPK is less than 4 times the upper limit, stop statin for 2 weeks. If symptoms persist, go for a statin re-challenge or find other causes. If symptoms with CPK more than 4 times the upper limit, stop it for 4 weeks. CPK normalizes, symptoms resolve. Second statin, you can change from Rosuva's to Aterva, Aterva to Rosua in small dose with usual dosing of 1, 2, 3 times per week. Later on, if symptoms recur, stop it and start low dose of third statin like pitavastatin, which is available. If LDL targets are achieved, yes, continue. Not achieved, go for non-statin lipid lowering drugs which are available. Rhabdomyolysis, no statin again, go for non-statin lipid lowering drugs. To summarize, there is a greater prevalence of hypercholesterolemia in patients with IHD, particularly premature IHD, and in population with severe hypercholesterolemia. And it is a major risk factor for CAD, and lipid lowering plays a crucial role in pathogenesis of ACS. Reduction of lipid parameters plays a pivotal role in secondary prevention. Intense lipid lowering therapy with rapid achievement of LDL-C target goals in ACS patients seems reasonable. If goal is not achieved with high intensity statin therapy, then you must always think on adding PCSK9 inhibitor, bempedoic acid, ezetimibe, or inclisiran to the standalone therapy. A proven concept in LDL cholesterol management in ACS is hit hard, hit early with combination of lipid lowering therapies to reach the target. A significant portion of Indian population suffers from atherogenic dyslipidemia, that is raised small dense LDL cholesterol and triglycerides with low LDL cholesterol, recommended to initiate high intensity statin therapy, and a significant portion shall also require addition of ezetimibe. Despite the acknowledged clinical benefits of LDL in patients with ACS, the attainment of LDL target values remains suboptimal in this very high risk setting. Thank you. Floor is open for discussion.
Thank you, Dr. Abhishek, for that comprehensive talk and description of the journey of statins in general and in acute coronary syndrome in particular, and very nicely summarized in the last 2 slides about how we have to treat patients very intensively, because acute coronary syndrome is a different cup of tea. It's not a stable angina, because there is also a question of not only a question of acute mortality, but they also have recurrent events, and their long-term mortality persists. Long-term risk of events is about 5%, which is lifetime. It never becomes zero. So we have to focus on these patients. And like you rightly said, hit hard and hit early. I now invite my co-panelist, Dr. R. Ravindran, to make his comments, and then we can answer some other questions and then have some concluding remarks. Thank you for the wonderful talk and the great effort and time you have put into it.
Thank you, sir.
Dr. Ravindran? We can start reading the questions in the chat. If Dr. Ravindran is busy, he can make his comments in the meanwhile. Are there any questions in the chat box? Dr.
We'll
Rishi,
get those questions if there are any. So by the time you can raise questions if you want to discuss with Dr. Abhishek.
Yeah.
Sir, your take, sir. So in ACS patients, you generally start with a single statin at high intensity statin like atorvastatin 80, rosuvastatin 40, or nowadays you start going with combining straight away. Any ACS patients walks into our emergency room, you start combining them with ezetimibe.
With ezetimibe, yeah. That's a very pertinent question, because in the Indian scenario, when we see especially younger patients with multiple risk factors, I think we should hit it really hard with a combination of 80 mg of statin. In fact, we are one of the groups which started high dose statin therapy right in 2004, as early as 2004, about 20 years back, when we were criticized for using 80 mg of atorvastatin at that time. People thought it was too high, it will cause myopathy and all that. But what I've seen from the experience of the Reduce It trial and then the Horizon trial, where we are seeing what pelicarsen is doing to the lipid LPA, lipoprotein little a, and then the inclisiran in primary and secondary prevention, is that patients who are compliant with high dose therapy for a long time, I do not reduce the dose of statin at any time, irrespective of the LDL. That is what I've learned now. People, if you think you have reached the target and try to reduce it to 20, the LDL will bounce back and swing and cause events. So once they are started or stable on 40 mg of atorvastatin, they remain on 40 mg lifelong. Unless they complain of severe symptoms, we will still try to convince them. So considering the use of combinations, like in every disease, like take for example diabetes and hypertension, where initially it was a single drug at a high dose and then add a second drug, and that approach has now gone. You can consider combination drugs, especially ezetimibe, which has almost a placebo-like profile. Apart from the flatulence and some GI side effects, it doesn't cause much of side effects. So with 40 mg of statin and 10 mg of ezetimibe, you can certainly take care of those residual outliers. Means they have reached a LDL of say 75, wanted to get it below 70, or if they are around 60, you want to get it to 55. Those kind of outliers, a combination is particularly useful. If it is not controlled with that, I tend to add bempedoic acid or bempedoic acid ezetimibe combination. And at any time you see a statin intolerant patient, we go on to inclisiran or evolocumab. The other thing of late we are doing, maybe strictly not by label, in the past 1 year, is offering the patients the benefit of evolocumab or inclisiran, especially in high-risk patients, if their LDL is more than 130 in acute coronary syndromes. Acute coronary syndromes, TIAs, and acute strokes, we counsel them to take that. Many patients decline because of the cost, but in those who have some kind of insurance coverage or able to see the benefit of taking a quick reduction in LDL, we have used evolocumab in this situation. So we should consider acute coronary syndrome as a separate category with where it is carrying a very high mortality risk and a 30-day recurrence risk is high. So hit them really hard with whatever you have. Don't keep anything in reserve. Whatever you can offer them, whatever the patient is acceptable to, give it and achieve your goal of a significant reduction and a quick reduction in LDL. It's not only the levels which matter, it is the pleiotropic effects, the plaque stability, the cooling of the plaque that is important, the passivation of the plaque that is important to prevent recurrent events. So this is what I wanted to say about ACS. Dr. Ravindran has come back.
I think he has not, sir. I agree with you, sir, that I do also in these last 6 years of my practice, I never reduce the statin dose. If patient is insisting on the dose, what I do is I'll just change atorvastatin 80 milligrams to rosuvastatin 40, which is making them very much happier.
Excellent. That's a good thing. And also, when they are kind of reluctant to take 80, give 40 and add ezetimibe.
Ezetimibe, yes, sir.
Use the dose of 48 milligram because it comes in combination, like in that gold combinations and things like that. I separately add atorvastatin 20 milligram in addition. So which is like they get 60 milligram, not much of side effects. You try to achieve your target. So whatever statin you use, whatever dose you use, always try to get them to the target levels. So there are some questions in the chat box. I think Dr. Abhishek and myself, we can answer these questions. How early after an ACS event should lipid-lowering therapy be initiated? This is already clear in the guidelines. We use high-dose atorvastatin as a loading dose. That means in the emergency room itself, patient receives along with antiplatelets, whatever you want to give, ticagrelor and aspirin. Patient requires patient gets 80 milligram of atorvastatin in the emergency. So early, that is the earliest possible thing that is within our hands. And why immense the question we have answered in the talk. So I will not go into the why of it, but definitely very early and at a high dose. Dr. Abhishek, you want to take that or take the next question?
Yes, sir. What is the role of
lifestyle interventions in managing
dyslipidemia in ACS patients? Which specific lifestyle measures are essential in management of these patients? So coming to this question again, lifestyle in the sense, majority of the people are now habituated to the fast food services, sedentary lifestyle, and we don't bother about ourselves, and we'll be just going for the easy things. So exercise has to be the key role, and we must know what we eat, especially avoiding the trans fats, fried foods, going for more of a stir fried or boiled cooked vegetables. Lean meat has to be limited to one extent, and balanced diet. Like you have to cut down your plate to 4 portions. In that, one portion must be only a cooked vegetables or green leafy vegetables with one portion of fruits and one portion of some protein. If it's a vegetarian, you can go for the vegetarian-based proteins, or a non-vegetarian with some amount of non-veg protein, and limiting your carbohydrate intake to other half of the portion, and exercising every day. All these are the lifestyle modifications which we emphasize on patients. And on top of this, you must stay compliant to the medication, never skip any dose of the medication, and be on time for follow-ups.
Excellent. Very nicely summarized. And Dr. Ravindran, do you want to take the next question or share your thoughts about the role of statin therapy, treatment of dyslipidemia in ACS in general, or in particular with this particular question? Your experience regarding specific challenges in managing dyslipidemia in patients with ACS who have comorbidities like diabetes and chronic kidney disease, which is a big population in our country.
If the patient is not tolerating those high statin or required amount of statin, we have to use the non-statin therapy, or we can check whether the patient is tolerating minimal amount of dose of the statin according to the patient's symptoms of myalgia.
Do you have any concerns about high dose statins in chronic kidney disease?
Particularly the patients complaining of are not tolerating the high dose of statin with myalgia and other things. Definitely, I think we have to consider a reduction. Those are changing other non-statin therapies.
Go to a combination with a statin at a low dose. Yeah.
Yes.
So what should be the long-term follow-up strategy for ACS patients with dyslipidemia to ensure adherence and prevent recurrent events? Dr. Abhishek, you want to answer that?
Sir, it depends from physician to physician actually, but what I usually practice is immediately after the first ACS event, I see my patient within first a week or 2 weeks based on their distance from the place where I'm practicing. And after the first 2 weeks, I'll just reassess them, reassure whether they're on medicines regularly or not. And I'll see them after 4 to 6 weeks later on. And every 3 months, I will see them in the first 1 year. After the first 1 year of the therapy, I just try to stratify them whether they are a compliant patient or non-compliant. If it is non-compliant patient, I usually ask them to come every 3 to 4 months. So compliant patient, I see them twice a year after a year of ACS event.
Excellent summary, and it's so important to keep that intensity of ACS through the follow-up, because whenever there is a event, the patient tends to be compliant, but once they get well and get rid of the symptoms of ACS, they tend to become lax and drop their dose of statin or drop it altogether or discontinue medicine. So this is the time when the physician's role becomes extremely important in emphasizing that It is not a disease which goes away. It is a disease burden which they carry throughout their life. The risk of recurrent events, especially in the first early period after an ACS, and also in the long term, the risk of death is 5% every year. It doesn't go away at 1 year, 2 years, 5 years. It persists. So when you emphasize this point, maybe it will stick in their minds and they stick to their medication dose and be compliant. And also tell them that the patients who do well over long term, we have now seen patients like 25 years. This is my 25th year of practice in cardiology. The patients who are compliant to therapy, they are a perfect lot. They do much, much better, I would say, from my own experience with respect to recurrent events and various MACE events and things like that, and polyvascular territory events. So they do definitely well with all the therapies if they are compliant. So this is the point we want to emphasize. There are a couple of more questions. Dr. Ravindran, you want to take the next question? Role of rosuvastatin and ezetimibe in combination therapy. I think that is answered. Your opinion regarding therapeutic usage of PCSK9 in the management of dyslipidemia post-ACS, I think that also we have answered. There is some criticism that there is not much data about these newer agents, especially evolocumab and inclisiran with respect to ACS, the hard endpoints. No doubt it reduces the LDL by more than 50%, 50 to 60%. We see LDL values like 20 and 30, which we have never seen before with whatever dose of statins. That's what we are seeing. But does it translate really into reduced events? That is a question that is being asked now. There are some small trials which have shown very significant benefit in terms of MACE reduction, MACE event reduction. The 4-point MACE has significantly reduced, but large randomized trial data is still missing. That is one missing piece in this puzzle. And once we add that, it would convince every one of us to use these agents wherever we can, especially in the situation of acute coronary syndrome, to give better outcomes to our patients. Any more questions? I think that's all the questions in the chat box. Dr. Ravindran and Dr. Abhishek, you want to add anything? Otherwise, we'll wind up the session.
So we're on time, so I think we can wind up the session.
Yeah, sir. I request you to give your concluding remarks, sir.
Yeah,
Krishnamurthy, sir.
A few. Sorry. Yeah, please proceed.
So, sir, just one small question from my side, sir. So, sir, how you differentiate, like we have the rosuvastatin 10 plus ezetimibe 10, then we have the 20 plus 10 and 40 plus 10. So, sir, for what type of the patient you select the 40 by 10, or for what type of the patient you choose the 10 by 10s? Like any lipid parameter you consider, like at this stage 10 by 10 is fit for this patient. How you go, sir? What is the approach?
Yeah, in secondary prevention, especially ACS, I would use the highest dose, that is 40 plus 10. That is what I would use in ACS. In primary prevention, the dose depends on the lipid levels. In secondary prevention, I do not look at the lipids at all. On day one, where do you have the lipid value? If it is done within the first 8 hours of myocardial infarction, you have a value. Otherwise, you're treating them blindly and try to reduce the LDL. Hit hard, hit fast. Don't look at the LDL at all. That's what I do for ACS. For non-ACS, we are more selective. In primary prevention, we counsel the patient, more emphasis on lifestyle modification, especially the non-diabetic patients. They already read up. Google is open to them. So they ask questions like, what is my risk of developing diabetes? I tell them in India, there are only 2 populations, those who are already diabetic and those who are yet to be diabetic. They'll always be impressed by that. And even people with high HbA1c, not at diabetic, impaired fasting glucose patients, they are at higher risk of cardiac events, actually, if you see that population. So they're able to convince them easily. But the typical patient in primary prevention who comes for a health check with very few risk factors, and he doesn't have family history, he is not a smoker, they are difficult to convince. For them, we give low dose statins. It is reserved for that group of patients. So
Understood, sir.
Talks in my concluding remarks, I would say I would encourage all my friends and co-physicians to look at this problem seriously. Do not get confused by conflicting information. People talking about lipids don't matter, you can eat whatever you want, cholesterol levels can be anything, still events will occur. Don't look at that at all. The data of association of LDL to cardiovascular events is kind of uncontroversial. It is beyond all doubt. By the volume of evidence, by the sheer volume of data, the association is extremely strong. So you always look at reducing what we discussed, reducing the LDL to targets and keeping the LDL at targets in the long term. And in patients like the LI guidelines, Lipid Association of India guidelines, when you see an extremely high-risk patients, category A, B, and C, where they are very much prone to recurrent events, don't look at the LDL, beat it down to 30 or even lower. And in patients where you have got the LDL to your target and patient somehow escapes and has an event, what do you do with that patient? That is an important day-to-day practice questions. In those patients, look at the residual risks. Apart from LDL, patient may have high TG, that is one. Patient may have lipoprotein A abnormality, try to treat that. Now treatments are now available outside the clinical trials also. And patients may have a residual thrombotic risk, which you treat with a dual pathway inhibition by using lower dose of rivaroxaban. There may be a residual kind of risks arising from inflammatory component. Inflammatory component is now coming up as an important risk factor. So you do the HSCRP. If it is higher than 2, you try to address it with low dose colchicine. In acute coronary syndromes for the past 2 years, I think we have been using colchicine in low dose. Very significant reduction, 30-day reduction in recurrent events. So these are all some of the kind of residual things you have to look at. In the appropriate patient, look at inclisiran, though it appears expensive at the present moment with increased use. Actually, when inclisiran was launched in India, they came and had a kind of a pre-survey at what should be the cost. I told them, look at the burden of cardiovascular disease in India. It's a huge burden and young population. So if you are really concerned about getting our LDLs to targets, launch it at something like 20,000 or 25,000 with the company. Of course, they didn't agree. But if they had launched at that price, their volume would have been tenfold sale by this time. So that was my sincere appeal to them. But in course of time, definitely these costs of these molecules will come down. There are several other molecules on the horizon which may be administered once a year, and that would significantly decrease the cost burden. And that's what I was talking of, the anti-atherosclerotic vaccine, so that we can vaccinate our population whom we think are at high risk, especially in secondary prevention and high-risk primary prevention. And those are my remarks. And thanks to Emcure once again, and thanks to Dr. Abhishek and Dr. Ravindran for participating so actively and wonderfully, making it a very good learning experience for me too. Thank you all.
Thank you, sir.
Thank you, sir. So we are nearly at the finish line, but before we conclude, let's express our gratitude to all those who made this program possible. I extend my deepest gratitude to our distinguished speaker, Dr. Abhishek Kasa, sir, for his insightful presentation. Your deliberation has undoubtedly expanded our understanding pertaining to management of dyslipidemia in ACS. I would like to express my sincere gratitude to our esteemed moderator, Dr. C.B. Keshavamurthy, sir, and panelist, Dr. R. Ravindran, sir, for sharing their research, knowledge, and expertise with us today. I would also like to thank our esteemed audience for their active engagement and making this program a resounding success. On behalf of Emcure, I extend my heartfelt thanks to everyone from sales, marketing, and medical team at Emcure who have contributed to this program's success. Let's carry this knowledge into our practices, research, and advocacy, fostering a healthier future for dyslipidemia patients. Thank you once again for attending and encouraging us. Good night and good time ahead. Thank you.
Thank you, sir. Thank you.
Thank you all. Thanks to the
Thank you.
audience. Yeah.
Thank you.